Hello, and welcome to Conversations with One Yukon, a Whitehorse-based podcast where we discuss the latest happenings in Yukon's healthcare system and answer your most pressing health and wellness questions. I'm your host, Mathieya Alatini, and I'm zooming in from the traditional territories of Ta'an-Quechan Council and the Kwanlin First Nation here in Kwanlin U, or Whitehorse, Yukon. This podcast is brought to you in collaboration with the One Yukon's newest initiative, Ask Auntie. The first installment of this initiative is the launch of our first ever online resource directory. This can be found under the Resources tab on our One Yukon Coalition website at oneyukon.ca. We would like to thank Science Up First and their initiative Together Against Misinformation for helping to support our Ask Auntie campaign. Science Up First is an initiative created by the Canadian Association of Science Centres that helps to share the best available and accurate sources of any science-based information, helping to combat the spread of misinformation. If you would like to learn more about their specific work and how they support external initiatives like One Yukon's Ask Auntie, visit their website at scienceupfirst.com or any of their social medias at Science Up First, all one word. Ask Auntie aims to be a culturally respectful initiative that helps provide local resources, advice, and clarity on complex topics. We want to combat the misinformation that exists around health-based matters. We want you to have trusted resources. This podcast is just the first of many more Ask Auntie partnered episodes to come. Don't know who to ask? Ask Auntie. On today's episode, we are excited to welcome Dr. B Rourke, a leading figure in the fight against HIV and sexually transmitted and bloodborne infections, also called STBBIs, in Canada. Sean is a clinical neuropsychologist and a scientist with the MAP Centre for Urban Health Solutions at St. Michael's Hospital, Unity Health Toronto, and a professor of psychiatry at the University of Toronto. He is a director of two national centers funded by the Canadian Institute of Health Research that focus on finding practical solutions to the challenges posed by HIV and STBBIs. Sean has been instrumental in advancing HIV research, most notably leading the approval of Canada's first HIV self-test in 2020. His work with Reach Nexus through the groundbreaking I'm Ready or Ready to Know.ca research program is aimed at increasing access to HIV self-testing with the ambitious goal of ending the HIV pandemic in Canada in the next few years. Beyond innovation in testing, Sean and his team are dedicated to tackling systemic barriers like stigma, racism, and discrimination that prevent marginalized communities from accessing care. Today, we'll dive deep into Sean's pioneering efforts to transform HIV testing and care in Canada, the work he has done in bringing communities into health research, and combating misinformation that surrounds STBBIs in Canada. I've had the pleasure of working with Dr. Rourke over the past year, and I'm very appreciative of his abilities to get shit done. Welcome, Dr. Rourke.
Thanks so much, Mathieya. It's a pleasure to be with you.
Where are you calling in from?
Yeah, so I'm calling in from Toronto, and I've been here in Toronto since 1995, and at St. Michael's Hospital, and want to acknowledge the sacred land on which my center, the MAP Center for Urban Health Solutions that you mentioned, St. Michael's Hospital, Unity Health Toronto operate. It's been a site of human activity for over 15,000 years, and this land that I'm on is the territory of the Huron-Wendat and Petun First Nations, the Seneca, and most recently in the Mississaugas of the Credit First Nations. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederation and Confederacy of the Ojibwe and allied nations to peacefully share and care for the resources around the Great Lakes. And today, the meeting place of Toronto is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work in the community and on this territory, and also mindful of the broken covenants and the need to strive to make right with all of our relations. So real pleasure to be here and as part of our work, and thanks for having me.
That's great. Thank you for that land acknowledgement. That is so in-depth and really recognizes those past relationships and the broken covenants that those old treaties, those historic treaties with the wampum belts that are part of Canadian history that we don't get talked about very often. So I appreciate that. Sean, you've been a leader in the HIV and STBBI research for many years. Could you start by telling us about the work you're doing currently?
Right. So, I've really had the great fortune of being recruited to Toronto back in 95. And just a bit of context for HIV then, like that was the year when combination therapy, the cocktail as we used to call it, was coming online, and we thought there was going to be amazing things that happened, and there were. And you sort of fast forward today when treatment is so simplified, it doesn't have side effects like it had initially. And, with all of the, treatments and the access points for people to be able to get tested, to go on treatment, to have an undetectable viral load, to be undetectable and not be able to transmit the virus to other folks, and what that means to a person and partners and community. It's remarkable, the progress. But I came at a time when there was concern around, what about the brain? And so as you indicated in my introduction, that my specialty where I started was in clinical neuropsychology. So I've been started the first clinic in Canada to evaluate people who may have concerns around their cognition, about their cognitive ability and their mental health, and set that up at the Wellesley and St. Mike's, and really built it in a way that helped us understand more about what was going on. So what are how to help the individual person with this, but also, set it up in a research program where we could understand how things were evolving, and with the scientific discoveries that were happening, how might that change how we think about interventions and helping support people. I can tell you that there still are some issues with mild cognitive problems that can happen, but with treatment, we've eliminated the AIDS dementia that we used to see. If somebody gets access to treatment, that will not happen. And so, there's still the issue as we all get older about things that the body and HIV and the medication still can do things to cause it to age sometimes even more faster than for everyone else. And so we still need to sort of keep on studying this. So that's where I started. And really it was along the way I got involved more in community-based work. So I've been doing that for a couple of decades now. And I was recognizing at the time that I was doing my work and building this program in the hospital and supporting the community in Toronto and outside, that I could do more to sort of advance the agenda. Like I sort of like got this impression, or that there was more to it than just doing something in the office, or doing this work to understand the research side of things. And the community, as you know, has always been central to the solution for HIV and AIDS. And so I got introduced into that, and really got much more involved in community-based research, and actually here in Ontario, worked for the government to help the research policy for many years as I was doing my other clinical work. But it's really led to a place in the last 5 years where I've recognized that, listen, we're a country where people should not be getting HIV anymore. The treatments should be available to everyone. And that's not happening. So it really started there, I think, as part of our center work. And we were tackling things like housing and food security, did some really wonderful work in understanding, housing is health. Housing is good health care. Housing is good policy, and really helping to advocate for people living with HIV to have other things that they need for housing. And back in the early days, if somebody didn't have a roof over their head, how could you take care of all the complexity of even the medication? So there's some simple things like that, but we've come a long way. And so in the last 5 years, it's really sort of recognizing that we needed a way to sort of look at how to make sure that every Canadian, everybody that was affected by HIV, that had HIV and didn't know it, they were undiagnosed, that they got access to the testing that they needed and the treatments that they needed to support their health and well-being. And obviously, now that we understand this incredible power of the U equals U message, that was a huge public health benefit for really addressing HIV. So that's kind of where it started, kind of where my work started as a clinician. But I really expanded that, and today see myself also as a community leader that work, in partnership side by side with so extraordinary people and agencies to figure out how you fix the system that isn't working for some people. So that's kind of
Mhm.
where we are, and what we often talk about the people who are underserved and not getting what they need
I
shouldn't
like
happen.
that approach of that holistic approach, especially from the housing, like housing first, and then we can help you take care of all of your other health needs. Such a it is not unique approach, but it is such an important approach to creating well-being for individuals who may have contracted or who are at risk of contracting STBBIs, HIV especially. I do want you to talk a little bit more about the U equals U
Mhm.
and the I'm Ready campaign.
Maybe I'll start with the I'm ready. So, if we go back a few years, about 4 years ago, November of 2020 was when we got the first HIV self-test approved in Canada. So this was a really pivotal moment in so our governments, first of all, the industry, the manufacturers that make these tests were not coming to Canada. And and it was very surprising to me. Like, why wouldn't we have a self-test? Like other countries, G7 countries have them. Why wouldn't we have one? Not everybody, as we know, for lots of reasons we're going to get into in is the conversation around. There's a lot of people just have had terrible experiences with the healthcare system and the public health system, and because it's treated them very badly, and we need to fix that, and we need to figure that out, and that's a longer issue to resolve. But I was really struck by the fact that we didn't have this option. And so remember, that was before COVID. And so we were doing this work, and so we had started it, and I think we're going to dive in. And so I was very surprised that our governments, I just expect governments are here to support the people, right? And so why aren't they, bringing these folks to the table? And we got a large grant from the Canadian Institutes for Health Research. And at a time when our center called Reach Nexus got it refunded, but I also got this grant to do testing and connections to care. And I remember some people telling me like it was one of these tracks, like grants often have these different foci, something or for this health area or that one. This one was more of the clinical therapeutics. And I remember people telling me, Sean, you're not going to get it. It's trying to put a square in a round hole or whatever, round. And but I got I was fortunate to get funding for both. So it allowed us, our center, to have the people, but the other grant gave us, and we talked about, we're going to get tests approved in Canada to reach people who need to get tested. And so we
Mhm.
set out to get two HIV self-tests approved in Canada. And I can tell you that we're almost 5 years into it. We got one that was approved in November 2020. The second one, so that's a blood-based test. It takes a minute. It's by a Canadian company called Biolytical in Richmond, BC. And it is over 99% accurate, right? So you can get this test and know your status right away and make decisions about your health. And there obviously needs to be confirmed with a blood test, but it allows people to start to recognize, to know their status, to make decisions for themselves. So we got one approved, and we got the second one. So that one's a blood-based test. Again, takes a minute. But there's also another one that uses oral fluids. It's like a swab your gums back and forth and put it into a cartridge. And within 10 to 15 minutes, you get a result. And it's made by a company called OraSure, and it's a product called OraQuick. And so we've done that study. It's submitted for publication. The other one is, well, it's already published. And we're working now with the company to get it licensed in Canada. And so we're just about to submit. And so in the new year, we're going to have a second option. And so why is that important? Not everybody wants to like, people get a little icky sometimes about blood, but it's also not always the context for this one test. You kind of have to have a table and lay things out. The other one you can do kind of on the fly in the field in the community. And so having these options was really important, and really felt that also we wanted to drive competition. And so we're going to get there. We have two, and we'll talk about the other ones that we've done. But that started us. We had the first one, and then COVID hit. And we had this large gathering in Canada that was funded by the Public Health Agency of Canada, brought all these community partners together and said, okay, before COVID hit, we're going to roll out this test and have frontline agencies just go nuts. Like have them really, they were the ones who would know where the people is that we want to reach and support and be the trusted sources for that. And we'd use that infrastructure to go. COVID hit and we had to pivot. So we built an app. It was called I'm Ready. And it's, essentially as easy as downloading on your phone and your iPhone or Android. And you could order kits, these self-testing kits, right on your phone and have them delivered to where you live, your home or where you lived, and or where you were. And also at the same time, we built into this information because we want to make sure, and people are nervous, right? So this is the first time and testing, oh, you need to be counseling this. So we wanted to make sure that everybody knew had the information that they needed. So we built it all into the app so you could connect with someone. Well, first of all, it was available for the do-it-yourselfers, right? Like, yeah, I'm good with technology. I can just log in. And we did that. We made sure that every person knew if you're in the Yukon or you're in, New Brunswick or you're in, Manitoba, you know what the care pathway looked like. So once you got tested and you had a result, if you're negative, well, how do we link you to prevention? How do we link you to things that you needed to keep you negative? If you're positive, where you get confirmatory testing and access to doctors and other things. So we built that all in. It really worked. We launched it actually in June of 2021, and that was a big event with Dr. Teresa Tam, our Chief Public Health Officer. I actually had our CEO for the hospitals on. We had 500 people because it was a pivotal moment in Canada for the first tests for HIV that you could do in the comfort of your own home.
I refer to it as bringing life-saving technology to the comfort of home. I think this is that type of technology that we got used to during the pandemic with self-tests for rapid tests for COVID. And this same type of test it saves lives. It is so incredible. Thank you for that.
And remember too, like remember initially with COVID, you had to line up and get tested with PCR, and you'd be lined up around. You had to go and get. Then you got a test you can do it at home. I think the backdrop to that we've been struggling with this in HIV and the STBBIs that we're going to talk about. That always having to go somewhere. Well, what if you could bring it home? So the technology is there, and people can make decisions. And I think what's important for everybody to know who doesn't know that you could do it when you wanted to do it on your own terms in a safe place too, right? So
Yeah.
you know, it's not going to doctors and sitting in an office saying, I'm going to get my HIV test.
Yes,
So
I think that's extremely important. And I do want to highlight that people, if they don't download the app, they can still just go to the website, which is www.readytoknow.ca, all one word, and they can see the pathways, they can order their test just off the website.
that's right. And there's a second option here as well, the IM program that bring that larger umbrella. We'll get talking about how we helped with the public health agencies, the government launching this program, which was very, very successful that they're pulling back on the funding now. But you can go right to a website and not even download the app. You can go right away and click on a button to get access to testing. So that's the i-am.health. So coming back to your other question, I sometimes a little bit longer sort of context there, but in all of that, the U equals U message of being undetectable equals untransmittable. This is a game changer, right? And there's a lot of work now happening in Canada, actually, this last couple of weeks. It's not getting to people. And this is going to change how we think about. So in science, so as a scientist, it's rare that you actually are in a situation where something is yes or no, is 0 or 100. And what we've learned from the studies, the clinical observational studies, the cohort studies around the world, is that if somebody's virus is undetectable, it's lower than 200 copies or less, they can't transmit the virus. There's zero risk, zero risk. It's not a little bit, it's not negligible. There's some words that we used to use. And those actually cause their own stigma and cause other things with doctors not wanting to be, oh, well, maybe it's, you should be careful. Like, no, zero risk. It's a way for people to just be in a situation where, they can have children, they can, have sex without a concern of transmitting the virus. There's zero risk in this. There's no transmissions that have ever happened in these studies, and we're talking studies for the last many, many years, and reports in all the biggest journals. When you think about, Lancet and JAMA and all these journals, that there's zero risk. So if somebody gets to that point, now we should talk about not everybody gets to that point, but most people do, and we have to make sure access is there for treatment. But it's a game changer because people don't have to feel the stigma of feeling that I'm going to be part of transmitting that if I'm undetectable. So it's amazing what this has done to change the situation for treatment, and it's remarkable.
So there's a couple of things that I want to unpack there. There's the piece around stigma and the role that stigma plays in people accessing or just even thinking about going to get healthcare or get tested, treated. What are some of the biggest challenges that you've encountered when addressing the spread of STBBIs in Canada, or even our discussion around STBBIs?
Right. Well, I think it's helpful to recognize. I mean, we do have a universal healthcare system, and and it's under significant strain, as we all know. And you can't read the morning newspaper without hearing about not enough people have a primary care doctor, not enough people have this or that, and that's all true. But it has been remarkable for people to get access to testing and treatment in Canada for HIV and other STBBIs, and it varies a little bit depending on what you're talking about, but you know, between 80 and 90% of people get what they need, and that system works well for them. And they tolerate it well, or they find a way to navigate that system. There's a group of people, a significant proportion of people that have, where the system has not worked for them very well, where they've been mistreated, where racism and colonization, all these things have created different contexts where people don't feel safe, they don't feel treated properly, they've been discriminated, and so they don't access the system because it makes their health worse. And so, I think we have to first recognize the context for this, and then how do we think about the things where we need to change, to address that. Everybody deserves to have equal access, right? So I think just to start, to emphasize, there's a good news story, but there's also, it only goes so far, and it's
Mhm.
not enough to this other piece. And everyone there should have the same rights to get what they need and the same opportunities. And I think that's where the stigma, discrimination, and barriers come in, where the work that you and I do and others is really trying to address. So I guess just to start there and to recognize the system where it's worked, but where there's these big gaps, and people fall through the cracks because of all of that, right?
And then because you're mentioning systemic racism, and right now we're seeing the politicizing of healthcare systems. It becomes headline news, and oh, it's these guys that have done it to us. When really we know it has been a constant struggle in our history of Canada, especially over the last 15, 20 years with universal healthcare. It's not a one and done answer to fixing all of this. When you look at some of the work that you've been doing and just addressing some of those challenges to discrimination or racism or accessing care for LGBTQ2IS plus, what are some of those best practices or ways that we can adopt or shift our healthcare system?
Right.
And yeah.
Yeah, no, it's a great question. And it's interesting, my answer is because you know me, like I'm always pushing forward. I tell my kids and the people I work with, I never look back. But here's a situation where you actually have to look back very carefully and understand what we've done wrong and where we've really, made huge mistakes. For a lot of people in this country, Indigenous, Black, racialized, a lot of people in different places, different contexts, we actually have to really understand that, recognize it, identify it, call it what it is, so that we can actually understand what's the way forward and how to change it. If you don't know where you've been, you don't know where you're going, one of these things, but it's also, you have to acknowledge the terrible things that have happened. And on the one hand, as a psychologist, I'm always trying to careful balance these things. Like you don't want to go too far, but you have to see it for what's happened because you just don't want to do it again. And I've, I've been so struck as I work in the sector, and particularly over the last 10 years, I've noticed, when I was growing up, how many things that you were talking about, the messaging and things that, like, how many things that we weren't taught in school or things that we sort of assumed it was one way or not the other. Like, there was a lot of things that were wrong. There was a lot of things that were happening, not too far away from where we live, that were terrible for some people, some communities. And you have to acknowledge that. You have to honor it in a way that respects, the experiences that people have had. So you can actually see how, first of all, you never want it to happen again. But how else you have to understand the context so you can actually help, the healing, the way forward in ways that understands the lived experiences of people so you can do it in the right way. So it's interesting for me because I'm always looking forward. This is one of those situations where you really have to understand that history and you have to understand the things that have gone wrong and the responsibility of the people who have done those things, and then want to be part of the change that happens and to work with people in ways that works for them. And in the early days of learning about community-based research, like I'm constant. I also say I'm always feel like I'm a grad student because it's a nice place to be. You're always learning, and there's so much still that I feel I have to learn. But it's remarkable where you have that kind of open mind, and I think it comes a little bit with age and maybe with a little bit of wisdom that you know what I don't have all the answers, and in fact, what's even better is that you work with people who know what it's like and you want to help them because the way I choose to do is my own way. And my job is to work to serve the communities that I'm a part of. And so if you want to do that well, you listen, you watch, and you ask where you can fit in. So there's a little bit of context there, Mathieya, about just there's a way to do it well moving forward that needs to be very different from what we've done before.
I know you are a bridge builder. You build those connections between community and the scientific community, Indigenous communities. And I do want you to talk a little bit about some of the First Nation community outreach that you've been doing, and maybe talk a little bit about, I'm going to say it, Ayakwamisiwin means carefulness and preparedness, that initiative.
Yeah, we're so excited about this because this goes back now a few years where, and you were part of these conversations. We're bringing everybody together, thinking about what are the problems and, what's happening in the prairies in the north and these places. And, seeing that, wait a second, like there's these terrible health emergencies that are happening. I was like sounding alarm bells. And part of it is I've got to a place in my career where, and this comes, I think, probably it comes with experience, but it also comes with just being around for longer maybe that and as a certain thing about let's get this done the right way, but let's stop and wanting to bring around the table the people who are the change makers, the people who want to see change and want to make things happen. And so the a young Kwamisuan initiative, really, then that name came from Albert McLeod, who's our elder, who asked him to be our elder in this, and he was the one that went and thought about, well, what's the grounding of this initiative in the prairies in the north, that recognizing these surging rates of HIV and STIs and syphilis and congenital syphilis, and it's just heart-wrenching to know that some of these things shouldn't happen at all. Like back 10 years ago, there's 0 cases of congenital syphilis. Now there's thousands, and that's a breakdown in the system. But as Albert would say, Sean, this has been going on for decades. It's things that have happened and that we haven't done the right things, made the right choices, work with the right people in the right ways. And so part of that, I think, Mathieya, is like listening to the people who know better and asking them about what we can do. So that's kind of how these conversations started. And then we were fortunate to get funding to actually, because it's great to have an idea, but it's all about implementing it. But making sure that the right people are around on the ground floor, that are there on a table, that we're listening to all the viewpoints and thinking about, well, what should we tackle? I mean, this is an initiative that's going to start very soon later in the fall, going to support 10,000 people to get tested, to know their status, to get connected to care. in the right ways, right? And there's a little bit, it's all different depending on whether you're living in Manitoba or Yukon, or everyone's going to do it differently, and you have to be able to be adaptable to context and the people and partners that you're working with. Say, well, Sean, this is how we should do it. So like, I'm the last person, like I'm just there to help, kind of, like you say, like, broker these partnerships, but also help us to just make it happen and get it going, because we learn by doing. And especially when you have the right people with good heads on their shoulders and their heart right close by to know you're doing it the right way. So that's how it started. And we're really excited. It's going to launch very soon, and it's going to make a huge difference in the lives of people in the prairies. And as you know, we have a grant that we applied for just a month ago that is going to bring in all our northern partners, Yukon, Northwest Territories, and Nunavut. It just makes sense to do it that way for they're all the right reasons, right? So
And I think that's such an important initiative, because it's not something that's talked about a lot in our communities, like the
right.
awareness piece of the transmission of STBBIs and the treatment of it. I think there's still a lot of stigma in our communities, northern communities. And it's discussions like this that I think we can start sharing. What are the facts? I want to touch on 2 points. What is available right now for testing, or the work that you're doing for testing and approval of that duplex unit, the
Right.
HIV and syphilis unit?
Yeah, so I'm gonna just say one thing about your awareness. I want to pick up on that. I'll answer that. So in Canada, we're a little too Canadian sometimes. We're shy about saying things, talking about where's the billboard? Where's the education? Where's the like? Listen, this is all about this is life. Like people have or sexual we're sexual beings. Like I just when you get a certain point in age, you realize, so why are we doing it that way? Why are we talking about it? And that's not far away though. Like we just have to have the right people and support them to say, "Hey, listen, talk about it." People want to hear about it. They want to understand. So I often say to when I'm working with colleagues around the world that Canadians are just shy. They're too conservative. They're Canadian. They apologize for everything. Don't apologize. Say,
I'm sorry, we're having sex. I'm sorry, we got
like,
STIs. Yeah.
no, right, right. So, and if people, had the right information, if they had a choice whether you get an STI or not, they probably want to know how to avoid it, right?
Yes,
Uh,
exactly.
it's just, and by the way, you can have fun having sex too. Like it's not, there's lots of, and I actually defer to other people who know a lot more about this. But we need to have the voices, the conversation need to be just explode more, right? So, but the testing options. So what we've done, I started to tell a little bit about the HIV options, but we have HIV and syphilis. So again, takes a minute. You can test for HIV and syphilis at the same time, highly accurate, and allow people to make decisions about having one STI or another, like having an infection or a STI, and putting it in the hands of people to be able to make decisions. And so right now we have one option for HIV and syphilis, takes a minute. We're going to have another one very soon, weeks away. So another Canadian company called Medmira. We're in the last stages of Health Canada review there, and that's part of my role is to bridge these things. And I know we had a conversation yesterday with the company, a few more things to do, and landmark work happening in the prairies to get this. So that this is, Amy Singh, in Edmonton, did these studies during COVID. We tested two devices, one's approved, one's getting approved soon. And just remarkable work with community. Stu Skinner, I was just on the phone with them earlier today, and Wellness Wheel in Saskatchewan. They took it and modified it and rolling it out there. They're testing a syphilis alone one, so people can get, if you don't want to know your HIV, you can get syphilis. With an interesting sidebar there. So in Saskatchewan, they weren't sure if people wanted to know their HIV and syphilis status together. Like they thought, well, maybe, and heard from people on the ground that HIV is very stigmatizing, and maybe the treatments or the access are not available in some communities, some Indigenous communities, let's say. And so, why would I want to know status? Because I would be ostracized. Why would I want to go through it? So I'll know my syphilis, but I won't. Turns out that when given the choice, 70, 80% of people would like to know both at the same time. And they do that. And it really mattered, not because of what the test they were getting, but the people that were supporting them for their testing and their connections to care. If you get the right people and community and healthcare folks that really don't bring stigma, don't bring other things, and really, patient person centered, and do
Yeah.
it in ways that really identify, people's ways of knowing and doing in their own worlds, like really, that people make a choice, they'll trust the people that are around them. That's actually landmark stuff that help. So we don't have to, we want to give people always the options, but it's remarkable when you can trust another person and say, well, you're going to help take care of me. I'd like to know both so I can actually address both. And so we have two there, and we have another pipeline of other tests that are going to make the testing for syphilis even better, to know active versus historical, and hepatitis C. And so a whole pipeline. But the idea here is, and have them available on I'm Ready or in our health box, or in other places where people can get them, and have them as self-tests so people can decide, hey, I'm comfortable going to see my doctor, going to the clinic, or having a healthcare practitioner do the point of care. But maybe sometimes I'm okay with that, but other times I'm not. And I want something where I can do it on my own. And so that's what we're opening that door and working with these companies to make sure that those options are there. So lots of choice and options that are here and are coming. And we just need to get our governments to pay for them so that, that's not a
Yeah.
barrier.
Um, you had mentioned bringing care, and I want to give you the opportunity to talk about the health box.
Yeah. So when we started our work with getting testing available to people, and it was COVID was starting, I got a call from Debbie Warren, who's an executive director at Ensemble, a frontline community-based organization in Moncton, New Brunswick. And she said, Sean, those self-testing kits that you now got, they're licensed and approved. Can I was at this health fair, and I saw these vending machines that were starting to think about not just put candy bars and sodas and stuff in them. Can we put health stuff? And so they were starting on the West Coast to put, harm reduction supplies in them. And she said, I'm gonna have to close my doors, with COVID. I'm gonna buy one. She used her CERB money, buy one. And she said, can I put this health? I said, Debbie, that's a wonderful idea. And I love it. And of course, and then we got talking about what else could go in it. She said, Sean, I have four other communities in New Brunswick that could really use one. And I said, really? And so she left it with me. She said, Sean, you're going to figure it out. You're one of those researchers, right? You go ahead. So I came back to her and said, Debbie, I think we should build a program here. And so we got talking about it. And it was really from her. I missed last week. I couldn't fly 2 weeks ago. She's retiring, and she's an amazing person. And so we launched in January 2 years ago, four health boxes in New Brunswick. In Moncton, half an hour away from Moncton. We launched in a snowstorm, by the way. When the snow was that morning, we got there and went to her place. The machine's outside. The snow's coming. The snow was already there. We were in 2 feet of snow. And they get snow. When they get snow, they get snow. Like, they didn't
They
get the
don't mess
National
around.
Command. They got snow. As the day was unfolding, the snow was still coming. The buses were being stopped, and she had to send people home. But our health box was outside of her front door, and it's on, and people could still get access to harm reduction supplies and self-testing kits. So we were there. We were in a small town, about a half an hour away, inside the vestibule of a United Church, where there was a minister that said, "Hey, listen, I'd love to have one in my place." Up the coast in a Kent Drugs pharmacy, where you come in the front door to get things. The people who get methadone come in the back door. It's right there for the people who are seeing a pharmacist for their addiction, could get access to other things that they need. And on the other side of the province in Woodstock, in the First Nations community, outside, right beside their health center. And each one has different things in it. Woodstock had smoking cessation kits. It had a bunch of stuff. It had seeds because they're an Indigenous community. Like, everybody is interesting. So we started there. We're in Manitoba now. We have three in Ontario. We have one Southern Alberta, Siksika First Nation. We're rolling out. So we have 10 that are in place. They're all different. Notre Boîte Santé, our health box. It's an amazing program. 3 years of support for these machines to put things in it to help people with things that they need to take care of their health. Has a connection to the social and health services so that we really try to help people navigate where they can get other services. And we're going to be in emergency rooms. We're actually in the Northwest Territories. We've working out. They're going to put one in a library. They're going to be in an airport and some health centers. And they should be in Yukon sometime.
Yes.
Well, so great program. It's working. And I have to, on Monday morning, go and testify, or probably it's not testifying. It's in front of, there's a counselor in Hamilton where we want to put one in, at one of the colleges there and actually in the emergency room, one of their hospitals. Doesn't think that we should have needles and crack kits and pipes and so forth, and feels that it's a danger to the community. I'm like, okay, I'm going there to say this is the most important thing that we can do to support people in their community. It works, it reduces stigma, it makes
Reduce
people feel about
transmission.
reduce transmission, naloxone kits to save people's lives. Let's not restrict it. Let's get away from it's all about misinformation. It's all about fear. It's all about understanding the people in your community that we're all serving. You're a counselor. You're responsible for those people. That's actually your job description. I have to say as the government, hey, wait a second. That's your job. You don't like it, go find another one. But right?
That's
So
right.
so it's a program that really works, and we're rolling it out. It's just another opportunity. It's a healthcare intervention. We have Staples Canada that's funding the implementation of all the machines in Atlantic, and we have other foundations that have been supporting. It's terrific, and it works. And it's just another tool in the toolbox. Although it's a big tool,
We've got a
1,000
Staples
machine.
here in Whitehorse. I'm sure we could
Well,
get from there.
well,
Right.
just say the word, and we can talk more.
Yes,
But,
absolutely. I'm glad you did a shout out to Dr. Ami Singh and all of the people at Wellness Wheel, because that, like, the work that's being done there is being used as a benchmark for other jurisdictions. And I know here in the Yukon, it's who we're looking to as a best practice for testing and test treat for
right.
anybody with syphilis. I think it's an opportune time for us to talk a little bit about maybe bust some myths about
Sure.
about illnesses, about STBBIs. When you talked about U equals U, and so undetectable equals untransmissible, right? Did I get that right? Yeah.
Yes.
Awesome. So U equals U. How do people, once they're testing positive for HIV, how do they become undetectable?
So the treatments for HIV, the antiretrovirals that are now available, one pill a day, even now injections, as you know, is coming down, is available options for people to not have to take a pill every day, but to get an injection. Those reduce, when they're taken, those reduce the virus in the body to undetectable levels and to very, very, very low levels of the undetectable. Like you can't, when you do the test, you can't pick it up, right? So there's like with most tests, you have a blood test, it detects levels of things. These have different thresholds. They used to be up at 500, then they went to 100, then they went to 50, went to 40, down to 20, 10. So when it means that they can't pick it up. So there's no virus that the test can pick up. And
Which is
so the treatments, and it takes a few weeks to get there, but the treatments lead to somebody having virus in their body, which should be really high, to that they can't detect it. And the medications are so durable. When you're in that place after X number of weeks, you can't transmit it. So somebody can have sex without worrying about having a condom if they're protection, and they can't transmit the virus to someone else. And so people can have that comfort. And it takes some time to appreciate that on one level, but on another level, it's like, well, imagine if you can't transmit it, you can't give somebody the virus, and what that does to empower somebody, and making sure that we need to do everything we can to have those treatment options available to everyone, everywhere, regardless of who you are and where you are. So if you're in a rural area, we got to solve that. If you're not getting it, how do we get to you? And here's where the technology and pharmacists online and nurse practitioners, like in Alberta now, pharmacists can prescribe. we're going to open up the door. The treatments are so easy to prescribe now, more so than ever before, right? And it just allows people to get the medications, get somebody to that place, and then allow them to live a life where they don't have to be concerned about the virus getting transmitted to somebody else, and they can have children without worrying about that as well, which was not
Mm.
possible many years ago.
And those drugs are called PEP, is it?
Well, so the medications to treat HIV are called antiretrovirals. And that's for people who have HIV. When we talk about antiretrovirals and the medications, they also have this incredible potential to prevent people who don't have the virus from getting it. So we talk about pre-exposure prophylaxis or PEP, post-exposure prophylaxis. So what does PrEP or mean? What does it mean? So it essentially means that if somebody's having unprotected sex and they get exposed to HIV, somebody that doesn't know they have HIV and they're at risk for acquiring it themselves. And if so you can eliminate that risk and have it down to almost zero by taking PrEP. And that is you take the medications, a lower dose of these medications, could be every day or could be at times when you know you're going to be sexually active in order to prevent a person who's HIV negative for not getting HIV. So that works, and large studies around the world showing that that's incredible prevention way of preventing somebody from acquiring HIV in the first place. And then you mentioned PEP or post-exposure prophylaxis. It happens when, condoms break or somebody was exposed to someone that didn't know and could be at risk for acquiring HIV. You can take it after the fact. It's not as good as the before, but it can also prevent somebody from acquiring HIV. So again, there's certain windows when you have to, for the post-exposure, you can't wait. You have to do this immediately. And unfortunately, it still happens more than it should. We need to provide more education around PrEP so that people can actually talk to their doctors about it, because doctors aren't talking to their patients about it. And again, we're Canadian here. Something's wrong.
That's
Um,
such a disservice. It's treatments that are readily available and that the healthcare system knows about and could reduce the possibility of people contracting HIV. It just is mind-blowing, but
We just finished a study which we presented, and we have data from across Canada that only about half the people that we surveyed, this is over 1,000 people living with HIV, 1,100 or so, and we asked them, has your doctor or your healthcare provider talked to you about U equals U, about the messages around prevention, about the medications and so on? And only about half of the people, 51% actually, said that they did. And even asking about that, that's just the conversation. Whether they talked about it appropriately or not is a whole different issue. So imagine only half. This is a medication that can prevent people from getting the virus. Like,
mhm.
and so again, this message isn't getting through, and doctors still think, well, it's still there's a little no zero risk. Let's get out there. And so there's campaigns that are going to be starting. And in fact, there's work underway just these last few weeks. Bruce Richmond from the Prevention Access Campaign, who really started this back in 2016, 17, has approached Canada and said, hey, listen, how can we get you more involved and open the door to some work that's happening in the US and around the world to start this thing called U equals U University. And it's going to be a place to actually for people from our communities in Canada, from all the key populations, to learn about how do you teach people and raise the bar around awareness around U equals U. And we're going to make sure that everybody's has has what they have what they need to talk about it in the ways that are going to reach and engage communities in the right ways about this message. And then separate things that are going to happen with our healthcare providers and our policymakers so they can start to make choices. Because if you know that data, it's like, why don't we just roll out the red carpet here? Why are we still, thinking some people get covered, some don't, it's huge. And it saves lives, and it actually saves a lot of money from the economic standpoint. But the human side of it is so striking, so dramatic. Nothing in science is ever this effective. So it's really crazy how we haven't embraced it as much as we have. So we're going to make sure that happens, and we'll make sure everyone in your neck of the woods knows about it too.
Yes, thank you. So, Sean, could you talk a little bit about the rise of syphilis that we're seeing in Canada and how important testing is, and so, some of the risk factors? I know you mentioned congenital syphilis. Maybe talk about that a little bit. What is
Right.
that, and what are the risks to individuals?
So if you look at the data in Canada for STIs, and there's a number of them, chlamydia, gonorrhea, syphilis, and so on, they're all on the rise. And they're all on the rise because our health and public health systems don't always meet people where they are. And we don't educate, as we were talking about, the awareness and education around these things, these conditions. There are other things I think that you have to point out too. There's certain places where the rise is even more exponential, greater, steeper increases, where it's moved from some populations, like syphilis, for example, with gay men, had a certain expectation. It's now more in heterosexual populations, and that's changing for a lot of reasons, but or for some reasons around some of the things that are happening when we talk about social determinants of health. So there are things that are happening around poverty and housing and what's happening with substance use and the opioid crisis and people using certain drugs that lead to more sex, places where people are not using protection or have other things to keep them safe. And so it's not sometimes just about these rises and it's because people are having sex and it's also these other things that have happened where there's huge gaps for certain people that don't have the supports that they need for their health and well-being when it comes to housing and access to mental health and addiction treatment and support. And so when you add those into it, part of the reason some of these have gone up exponentially is because of that. And with syphilis and congenital syphilis in particular, so this is when a situation where syphilis left untreated is really bad, but those treatments that work and they're very effective. The real problem happens when there's pregnant moms, carrying an infant, and if the mom acquires syphilis and it's not recognized, it has terrible consequences for their developing fetus and baby. And when I say terrible consequences, these can be very significant sensory things that happen where people can be deaf and blind when born. Sometimes in certain cases, 20 or 30% of cases where that the child's never born or they're born stillborn. These are terrible situations, and they should not be happening anymore. And congenital syphilis, was zero cases about 10 years ago. We're up at and part of our problem is too our data sometimes lags behind, and we don't have it. The numbers are off the charts. It's a health emergency. And for pregnant moms, it isn't just getting tested once in the first trimester, it's testing it before the baby delivers. So you can actually treat, because at the end of the day, it's a preventable infection that if they know that a mom has it, they can treat the mom and the baby. And this is a penicillin. It's not a penicillin you can take orally, but this is actually a shot of penicillin. It's not nice or it hurts to
Sean, what?
get a shot in the butt. I learned from the nurses, the public health nurses that I work with, that you can give them, people can have sort of something to sort of, make it not as painful for the injection, but that's what's needed. And it's often more than one dose. And so this is a real challenge for in those situations if somebody's has a very precarious housing situation or they're homeless or they have other things going on, their mental health or substance use concerns or issues, and just getting people tested in the first place. In certain places and certain populations, it's off the charts. I should say, there is some good news story here happening with the testing as we were talking about this point of care, and just when you start getting it to so many people in Alberta, and I mentioned Dr. Amy Singh, they're noticing in one of their zones, I forget how many zones there are in Alberta, there's like 6 or 7, but in one of them it's going down. And that's because of the investment and for people like her and others and others working in the labs like Kevin Fonseca and figuring out how to connect this with the programs and work. And so lots of challenges with their revamping of their healthcare system, but they're finding a way. And now they're working in other zones. So it is one place at a time, one community at a time. But coming back to your question, like these numbers are off the charts in some places, and they're solvable things. They shouldn't happen. And it's a reflection more of our lack of attention to the determinants of health and the things that people need just for the basic things on living. And I should say that the people that we're talking about aren't getting access testing for these conditions, but they're not also getting testing and support for their diabetes or for their other health conditions, which is not the way it should be in Canada. So, we really need our politicians and our health and public health systems to say, hey, wait a minute, you know what? We can't just always expect people to come in. We have to go to them. And that's largely what we're doing. We're building systems, community-based systems that go to the people in their communities and build it around them in ways that meets them where they are and reaches them in cultural appropriate ways that starts to address some of the reasons why they don't come into the healthcare system. And by doing so, we're sending a message that obviously we care about the people who are not getting served, but also that we're starting to rebuild that trust, and that takes some time, but doing it in a way that actually gives people options and helps them with their health. Everybody wants to be healthy, and everybody deserves that right. It's a basic human right in Canada, and it's always disappointing when our governments don't say enough about that. They fight about who gets money in this, but we got to fight for the people who need it the most. And if we
Mhm.
do that, everybody else benefits too. Like that's the other thing that you learn when you work in public health and population health. You serve the people who are most in need, everybody benefits.
Yes. And I think just stopping the spread, detection, getting those tests out there, stopping the spread, it saves lives. It saves babies' lives. I know our CMOH here has followed the national guidelines and recommended that women who are pregnant get tested 3 times for syphilis throughout their pregnancy. And just for that purpose of it may show up a little bit later.
And what happens too there is that somebody, might get, these are relationships, right? We don't talk about the other side of the equation, men and other, the men need to get treated as well. And they can reinfect person, right? So we need to make sure that we don't often, not to stigmatize men over women here, but we need to do more in not thinking about women are the ones alone here. This is two people have sex together, right? I don't think we do enough to think about how we reach both, and certainly the programs that wonderful stories from Amy and the people that she was working with, and how they'd find one and do partner, like get the other partner and make sure they're both tested and treated. Like it takes time and it's a lot of effort.
Partner has multiple partners. And that that's always a conversation. Don't be shy.
Don't be shy. Don't be shy.
Just listening to some of what you were just saying, the pieces around this is it's stigma that or fear of addressing challenging conversations. How do we reach those communities? If you had a magic wand, I love
Yeah.
that. How would we reach those communities that are hard to reach in our healthcare system, that are not going to see family doctors, that don't have access to care readily, or they've had those traumatic experiences with the healthcare system, or they're marginalized? Thinking of, well, our northern, rural, remote Indigenous communities, but also newcomers to Canada that need to know this stuff. How do we reach those individuals and increase the awareness of, I guess, not just STBBIs, but of healthcare and access to care?
Yeah, well, that's a big ticket. You always ask the most. You ask that's the difficult. So I think there's two parts to that. I think one is that, and I think first it's understanding that we're all human and we all want to relate to one another. So when we think about the messaging and the right messaging and the right things that people should get, and as you know, we're living in a world too where there's misinformation, there's things that are happening that, you're hearing, well, what's that about? So there's complexity in our worlds now. And with technology and AI, like it's troubling in some respects. But it really comes down to two. I mean, I think the one thing to remember is that, we're all relational. We all learn from the people around us, our parents, our families, our communities, our contexts, and who we relate with. A lot of stigma and discrimination happens. This is a starting point. Like, happens because people don't know better. They've gotten the wrong information or they haven't got the right information. And I think there's a lot of movement around, with use language as an example.
Mhm.
Language is changing how we talk about different things, even, sexuality, like talk about gender and sexual, how many different ways that people can identify now. And we should celebrate that, not make it something that is somehow, so it's scary if you sort of say there's more than just two genders, there's more than this couple of sexual orientations, right? We've seen this from the studies that we've done the last number of years, giving people choice to identify what's important to them. They're the one person, ask them how they are and
Yeah.
ask them how they identify as gender and give them choices to identify that. And that teaches us something about, what's normal, like what's part of just being normal or part of the world around you, right? And one isn't better than the other, one isn't worse than the other. It's just different, right? Like there's just facets of who we are as people, as individuals. And I think in restricting people, you can't read this or you can't know about that. Like I'm of the kind of just educate people about things about the individuals, the people, our brothers and sisters, the people, our family, our friends, and everybody can do something different. Like what's so scary about that? And especially in our world, like what's so scary about how you identify in terms of your sexual orientation? Like how does that threaten me? Like, but people have learned to somehow make that scary. It's fearful, and we have to unlearn those things. We
Yeah.
have to
I
learn
think
to educate. We have to learn that there's nothing wrong with that at all. It's just about human nature, and there's a lot of facets from the brilliant colors in our eyes and to whatever, the color of our skin. Like, it's just variation. And why should you be afraid or fearful of that? So, unlayering these things, we grow up thinking that it is this way, and you have to unpeel this and coming back to the language, like I often say to when we're talking about our stigma work, it's like, sometimes we don't say it the right way, use the right words. And like, I'm the first person to say, well, I didn't say it the right way. Like, so teach me, like, because I want to say it the right way. I want to engage you. I don't want to offend you. If I said it wrong, I'm sorry, I didn't mean it. And so part of stigma and discrimination happens because we don't allow the opportunity to ask somebody and just be okay with it's okay to be different. It's okay to get it wrong, but you got to learn from that. And I think that's the space. So starting there, I think Mathieya is the first piece of the, what we do about it is the mindset of understanding how this happens. And for most people, they do want to change it. And
Mhm.
they just have to give the opportunity. And so we have to stop being Canadian and teach people about gender and sexual orientation and lifestyle things that it doesn't threaten you at all, right? So
There's a lot of pieces there because stop being Canadian, but there's some of the things that you're saying are so Canadian. The prioritization of education, the principle of acceptance, empathy. Canadians are very empathetic
yeah,
people. This piece about openness and choice, those are very Canadian principles. But I think what we have to get over is being shy about
yeah, yeah.
tough conversation. Let's not be shy about this anymore.
Yeah, and I didn't go to answer your question, but you've opened the door. Like I'll come back to it. So that like really, how do we reach people? We got to start somewhere and just start the work. And I think it's like and I was using all this Canadian as not as a bit of a negative thing, but when they say, here you're Canadian, there's something that goes there. There's a sort of you're okay, right? And there's that empathetic. You're right. I find this in our work in our sector that we want to have it perfect before we make a change. And I think we have to just jump in and learn as you go, because we can't wait because there's a lot of people that are going to benefit. And you might get it wrong, you stumble a little bit, but that's life. Like just, say you're sorry or apologize in advance. But like here's where we just need to jump in and really, have those conversations. And so how do you reach people? You recognize that you need to know where it's happening and how do you get there? How do you get the right people the best people to talk on behalf of others wherever you are is someone from that community. It's always about going back, and that community can be large, it can be small, really small, but it's just thinking about that really changes how you think about the delivery. There's no, nobody wants to come in and tell somebody else how to do things. But if you have somebody else from that community speaking on behalf of them and having the right knowledge and information that helps to educate people, I mean, that's fundamentally the way to do it. And you have to be creative because we have such a large geography. But that shouldn't deter us. Like technologies and people have just figure it out. But
Mhm.
let's make sure that I think the principle though is to make sure that you have people who others can identify with. They're going to listen to people who are understand, their lived experience. And that's important. And I think, the more that you do that, the more successful it'll be. Most people today, I think, don't want to listen to someone else tell them they want it. They want someone that's familiar, that they can trust. And so that's important for, especially if in our world sector that we work. And so, bring the right people around the table and find a space for them. And Indigenous culture is so much like that, where people are brought around and, the traditions of talking and sharing things in ways like I always, look to and think, wow, there's so many wonderful things that happen in those spaces. We just need to just do so much more of it and facilitate those, right?
I think that really touches on the secret to success. I love that analogy of bringing people into the circle. That is very much an Indigenous way of being. If people want to be partnered or they hear this work that you're doing, how can they either join in the I'm Ready campaign or the Ayan Kwa Misiwin,
Yes.
I'll stumble over that, initiative, and whether that's getting testing out into the community, getting the knowledge out into the community, talking about U equals U university. How do they become partners and participate?
So it's just conduit through you or reaching out to me. Like we're open arms, really. Like I see myself in the work that we do and the people that I bring around to help connect. And I do this for this work, but a lot of like this part of the stage of my career, like help to navigate that. So people can just freely, reach out to me and I have a team that does similar to what the way that I do things and helps to just connect. And sometimes it's a few things, sometimes more than that, but we're here to help and we'll do everything we can, to make that happen. So the door is open, just an email or phone call away. People can, text and use phones. I'm
Yes.
happy to help because at the end of the day it's the work, the space that we work in and the work that we do that you just learn so much from just being around other people who are here's let's try to fix that. Like I'm a psychologist. If I wasn't doing this I'd be, I don't know, maybe I'm sort of have a little bit of a probably an art. I love working with my hands, and this is how I work with my hands and the stuff that I do. It's like I love putting things together to make it better. And I'm working in a place, as I mentioned, the hospital I work in. I mean, not too many people stay there for 30 years. It's because it's the extraordinary people. We just posted this morning. I was circulating. We're posting for a chair, an endowed chair in health equity and anti-racism, and it's like that's great. We have an institution we have somebody that's a director for this. We're now recruiting the best and brightest to build programs that is going to help us run clinical and research work to address a lot of things that we're talking about. And so when you're in a place like that, I've had the great fortune of just being around people that helped me get to where I am. And this is part of I think part of my role in life too. I'm realizing that in the last few years that it's time to give back. And I've always felt like, I'm there to serve, but when you've built up these relationships and, I can open doors, it's like, I often are asked, well, Sean, just connect me. And because, at a certain point, you're just older and more experienced, maybe. I don't know what it is, but I don't mind doing that, I guess is what I'm saying. I feel I feel a real honor to be asked to do it because it's or a lot of times it actually helps in some small way, for someone else or some other community. So a little
And
bit more there than just how to do it. a little bit more about my philosophy on of kind of where I am with my own headspace.
I think that's such a privilege to be able to work for an organization or an institution that is putting their money where their priorities are. So yes, producing knowledge, but also creating systemic change and actually putting money behind it. That's a huge privilege. So
And you know what they did? Are they actually have a report that you can read that showed where they're being, what they went out to do and what their progress and what they achieved, and be able to acknowledge where they didn't do it as well and where they failed. Like, I mean, I think that's how we learn.
yeah,
And there's this thing that you should avoid failure or you didn't do it right. Well, yeah, but the real way to I don't know in life is to acknowledge that it's just another part of life and say, oh, hey, I can do that better next time. And thanks for the feedback,
yeah.
right?
Only way
So
to grow is to fail.
right.
Otherwise, you just stay the same. I think there's something that you had mentioned about sharing and bringing people along. If you were to give advice to a young researcher or healthcare professional entering the field of HIV and STBBI research, particularly when it comes to stigma and improving care for vulnerable populations, what would that be?
First, I would say, don't be shy.
Yeah.
Jump, don't be shy. Jump in, and keep on asking questions and figuring out, what's going on and recognizing that you're just one view of this. And for things like this and stigma, there are all kinds of layers of this from the person to the community to the social constructs and social position, like social, okay, all these things. Just be open-minded and keep on pushing. Don't be shy to just ask the questions and make mistakes and figure it out and ask people what they think. Like it's a place to just learn a lot and be open. Like I think, part of stigma is breaking down stigmas, all the stigmas is just they're constructions that we make to somehow make us feel better or protect us. And they do nothing of that. They make everything worse. Like they do nothing but put up barriers between people and communities, right?
Mhm.
Stigma and discrimination is like there's no one better than someone else. Like, come on, get over that. Like, so, I frame it, ask it, be around and put yourself around people that know a lot more than you do to learn.
That's awesome.
That's what I would suggest.
And you're taking on mentees.
Yeah, yeah, I do, and I also make sure there's backup because as you know, we all get so busy. But it's the spaces to create. There's so much and so much we can do.
Mm,
It's creating opportunity, and there's a lot of people that don't get those opportunities, and in this space of that's happening at the hospital and the university, like it's remarkable to see the progress being made just to open doors and really correct some of the things that where we've done wrong. It's going to take some time, but it's all moving in the right direction. And it's nice to be part of institutions that, want to see change like that.
Sean, I want to thank you for all of your insight and for all of the work and your experience in this field. I know at One Yukon, we really appreciate the relationship, the support, your energy, and all of the work that you do to reduce stigma, to really address all of these challenges head on, and from a pragmatic perspective of just let's fix this. Let's do better. So I really want to hold my hands up to you and give
Well,
you appreciation.
thank you, but it's a real honor to just be working with you, Mathieya, and your team. Pleasure learning so much from you guys. It's great to do things together. So we'll just keep it up and, keep being pragmatic and pushing the envelope. It's the way that change happens but being sensitive to the way that we do it. So it's
Mhm.
wonderful working with you. So thank you for the opportunity to talk with you today.
Wonderful. Thank you. And that's it for today's episode. Thank you so much for joining us. And if you like what you heard, you can subscribe to this channel. You can follow us on Facebook and Instagram at One Yukon and on Twitter or X at one_Yukon. And our email is hello@oneyukon.ca. Any questions or ideas, flip that to us and stay connected.